So welcome everyone. Welcome to the first patient and occupational safety webinars. We are very excited to be here. So this is the first webinar 4, and this is about handling cancer drugs during pregnancy and breastfeeding. And the reason why we are here today is because on a questionnaire that we are going to speak about in a little bit, 43% countries did not have specific guidelines for occupational exposure during pregnancy or breastfeeding. And that's something that really scared all of us. So both Dr. Lena Sharp, good afternoon, Lena.
Hello, everyone.
And myself, Celia, will be chairing this session today. For those who may not know Lena, that is probably not a lot of you. She is EONS past president and the co-chair of EONS Advocacy Group. And for this webinar today, we have two absolutely wonderful speakers that will be talking about occupational exposure to cancer drugs, so we understand how important this is. And this will be presented by Dr. Lisa Kennedy, oncology nurse practitioner in the US. Thank you, Lisa. And it's morning for you, so good morning. Following Lisa, Christy Ranus, that is head nurse of the Oncology and Hematology Clinic in Estonia and a docent in Tallinn Healthcare College, will be talking about the cancer nursing management to reduce occupational exposure, so that after we speak how important this is, we can focus on how to make it better. We will have 4 colleagues sharing with us experience in their countries. And we, of course, will have questions and we will have time for comments and debate as we always have on EONS. As we are living in a world of changes and uncertainty, the speakers did record their sessions. So that's why you probably see them dressed one way, even if they are dressed in another way on the videos. But COVID times, it's much better for us to record it. So they are here today, and I would like to welcome all of them before we start. So hello, Lisa. Hello, Christy.
Hi, Celia. Great to be here.
Thank you very much for being here. Christy, are you around? Welcome. So welcome all of you and welcome everyone that is here today. It's very exciting to see how many of you are here today. This is translated in many languages. So I'm going to invite everyone to go into their own break rooms when we start, that it's going to be very soon. You will come back after the recorded videos for the Q&A. We will be all together. And this is going to be recorded and will be available on YouTube after this. So again, thank you and welcome everyone. Now, if you want to go to read in another language, please go to your own break rooms.
Welcome to EONS Patient and Occupational Safety Webinars series. My name is Celia Díaz de los Ríos, and I am going to give a short introduction before we start with the theme for today's webinar. We are going to be doing 4 webinars in this 2021. They are all going to be based on the EONS Safety Manifesto. The webinars are developed by cancer nurses and for cancer nurses, with the aim to raise awareness and increase knowledge. We have different world-leading experts as speakers, each of whom are going to be looking at the evidence and the clinical implications of each of these 4 important topics. All of these webinars, as many of you will be seeing today, will be translated into different languages to try to make it accessible to all. If you attend the 4 webinars, you will receive a certificate. And also, if you are interested in the credits, there will be the chance of doing an online test so you could ask your university for ECTS credits. We are very proud to have managed to do this webinar without sponsorship from industry partners. It is a very important topic where we don't want to be looking at any particular brand. We want to look at everything and how it should be done. The webinars are going to be accessible for 6 months after the event. So now, looking into the why of these webinars. Unfortunately, we still need to work a lot to improve patient safety. Healthcare has become more effective, but also more complex. In all healthcare, but especially in oncology, there are new technologies, medicines, and treatments coming every year. Our patients are getting older, and we are able to treat sicker patients with significant comorbidities. But this means that they have higher risk of experiencing medical errors. Of hospitalized patients, 1 in 10 will experience a medical error. Most of them could have been prevented. Unsafe handling of medication are very frequently reported. And we, nurses, the largest group in healthcare, we are in contact with our patients 24 hours, 7 days a week. So we are in a unique position to prevent those errors. If we look at cancer patients specifically, they are particularly vulnerable to harmful events. While we were talking about 1 in 10 hospitalized patients experience medical errors, 3 in 10 patients in oncology experience harm. Patients are exposed to complex and advanced treatment options with highly potent drugs with narrow therapeutic index. With cytotoxic agents that are the most frequent drug involved in medical errors, and a larger number of new drugs and oral therapies. And for them, errors may have catastrophic consequences. Occupational safety is very important, but unfortunately, often overlooked. There is clear evidence of the health effect from occupational exposure to hazardous and neoplastic drugs. PPEs reduce, but do not always eliminate risks. Most European countries do not protect their cancers from occupational exposure to the hazard drugs during pregnancy and breastfeeding. And even there are guidelines and recommendations, they are not always followed. Therefore, cancer nurses need formal education and training to minimize the risk for both patients, their families, and themselves. The EONS Safety Manifesto consists on 4 very important recommendations for cancer nurses. These series of webinars are based upon these recommendations, with one webinar focusing on each recommendation. The first recommendation is about pregnancy and breastfeeding. If you are planning to become pregnant or are pregnant or breastfeeding, tell your manager directly. Ask for alternative duties if you work with cytotoxic drugs, radioactive agents, or with open radiation sources. The second recommendation is on PPE. Nurses working with hazard cancer drugs should always use personal protective equipment in order to protect against the occupational risk of skin rashes, effects on reproduction, and even cancer. The third recommendation is about speaking up. Cancer nurses' actions are of great importance for safety. Safe procedures and the correct use of devices are crucial steps in safety promotion, as is the courage to speak up. The courage to question when adverse events occur in practice, including risk and including the near misses. The next recommendation concerns communication with and involvement of patients and their loved ones. As cancer nurse, you can always involve patients and their significant others by encouraging them to ask questions, to tell you directly if something is or seems to be wrong regarding any aspects of their care or of their treatment. This will reduce their medical errors and the risk of occurring. In this way, cancer nurses can contribute strongly to achieving high patient safety culture, will reduce the risk for both patients and staff. Here is some concerning data on safety from the EONS Cancer Nursing Index 2020. You can read more at EONS website. On the Cancer Nursing Index, they looked at different countries to see what safety concerns they have. Some of the results were that 45% of the countries provide no formal education before nurses handling cytotoxic drugs. Some countries have no written guidelines for nurses handling cytotoxic drugs. A big percentage do not have specific guidelines for occupational exposure during pregnancy or breastfeeding. And even worse, some nurses risk negative consequences if asking for alternative duties during pregnancy or breastfeeding to avoid occupational exposure. This should never happen. In 32 countries, systematic swab testing for occupational exposure are not performed, and in another form, only rarely and only in some workplaces. Then there are 22 countries that speaking up whistleblower systems are not implemented. And again, in another 5 are only in some places. In 14 countries, nurses report not always having access to cytotoxic spill kits and PPE. In 6 countries, clinical nurses regularly prepare cytotoxic drugs. And in another 11, this occurs sometimes. Fortunately, in other countries, these risky tasks are performed by pharmacists in controlled and adapted environments, like pharmacy labs. So this is the reason to be here today, to change this.
Greetings. My name is Lisa Kennedy Sheldon, and I have been a nurse practitioner, a teacher, a researcher, and mostly passionate about cancer care for more than 40 years. And I am honored to be here today to talk to you about occupational exposure to cancer drugs, issues before and during pregnancy and while breastfeeding. I love being a nurse and helping people receive the treatment and compassionate care they deserve after a diagnosis of cancer. Unfortunately, I have also seen the harms from being routinely exposed to cancer treatment drugs in my colleagues, problems such as leukemia and infertility. I've also seen the great improvements in safety guidelines and equipment, such as personal protective equipment, that are creating healthier work environments and protecting nurses from the hazardous drugs they handle, mix, administer, and dispose. Safety guidelines, including the use of personal protective equipment, can reduce exposure and harm from cancer drugs. Special considerations and questions often arise about exposure to hazardous drugs while trying to conceive, to get pregnant, during pregnancy, and during breastfeeding. These are questions for both women and men. I want to share with you what I've learned from the most available science and propose recommendations to protect you and your future families. Nurses are the largest group of healthcare workers around the world. According to the World Health Organization, there are 20.7 million nurses globally, making up 50% of the global healthcare workforce. As we know, nurses spend the most time with patients, so they're not just the largest workforce, they're the ones with the most patient contact. 70% of all nurses globally are women, and 68% of female nurses will become pregnant during their work lifetime. In cancer care, oncology nurses spend the most time with patients, talking, educating, giving treatment, providing support when needed, often all at the same time. We also administer the majority of cancer treatments, including hazardous anti-neoplastic drugs. Both men and women are at risk for the long-term low-dose exposure to multiple anti-neoplastic drugs. Unlike patients who receive a specific set of drugs for their cancer diagnosis, nurses are exposed daily to all kinds of hazardous drugs. They can have an effect on their health, their reproduction, and their fertility. These are not small issues, and I don't want to see anyone else affected by the hazardous exposure to these drugs. We know that when nurses are in the cancer settings, they're doing all kinds of things with hazardous drugs. They're manufacturing or mixing the drugs. They're helping with the storage after receipt. They're involved in the transport and distribution of drugs to both pharmacies, cancer centers, and also to patients. They actually are involved in the administration of these cancer drugs as part of treatment. After treatment, they have to dispose of the drugs and the equipment with the hazardous drugs on it. And often untalked about areas, we have to actually work with patients when they have to eliminate, so the excreta of urine and feces, and even the waste after treatment. This includes sweat. We're involved in equipment maintenance. We have to think about our colleagues and the shared work surfaces that we have and how we could be exposing our colleagues by leaving hazardous drugs and equipment on surfaces. And finally, worst case scenario, we have a spill of a hazardous drug, and we have to carefully clean up and dispose of that hazardous drug and make sure that the surfaces are clean. How do we know a drug is hazardous? Well, there's lots of different ways in different countries, and I'm from the United States, so I'll share some of the ones I know in the US, but I also want to make sure that we're sharing information from Europe as well. Any drug should come with a safety data sheet, an SDS, or a material safety data sheets. These come out of the manufacturing industry and the chemistry associated with the drugs, and it helps identify not just for nurses what are hazardous drugs, but for people who are loading a truck, say, with the pharmacy equipment, or involved in the pharmacy, in the storage of these drugs as well. Inside the package is usually my go-to resource to find that tiny piece of paper with a very small font that tells you about the drug, the different ways to handle it, some of the adverse effects. I mean, we use it for patient teaching and deciding on the right dose. But that package insert also has information about hazards, including issues related to pregnancy. The International Agency for Research on Cancer has a list of hazardous drugs, and you can look at that. And the most recent one being from 2019. And you'll see that there are numerous drugs used in cancer care on that list. In the United States, the National Institute for Occupational Safety and Health, NIOSH, has a list of drugs, which is currently under revision because we've had so many new agents in cancer care that we have to start thinking about what do some of these new agents pose in terms of hazards in our occupation. Drugs like immunotherapy agents. We don't have a lot of information. There is a drug bank, so I've put a couple of websites here. Both the drug bank and Daily Med are places where you can look up drugs and look at, are they hazardous or not? How should they be handled? In the United States, we have the Centers for Disease Control, and it also actually lists the NIOSH list I mentioned earlier. And there are special warnings that often come out from drug manufacturers, from the US Food and Drug Administration, and from the European Medicines Agency. There are ways to find out which drugs you're handling routinely are hazardous. Now, why do we talk about hazards? It's not just a hazard. There are specific issues related to the ability of a drug to cause cancer or birth defects. So let's just talk about these. So when you see these terms on a package or handling or on a hazardous drug list, you understand what they mean. By carcinogenicity, obviously, we're talking about the potential to harm normal tissues, to cause cancer. We've seen chronic exposure to some drugs result in bone marrow suppression, MDS, and leukemias even in nurses who are chronically exposed to cytotoxic chemotherapy. Reproductive toxicity can involve both effects on the ability to create eggs and sperm, as well as for the effects on the fetus. When it is effect on a fetus, it's known as teratogenicity. So there are multiple layers of thinking about the impacts of these drugs on fertility. As we go down around the circle here, you can see we also can cause serious organ toxicity, as we would with patients, whether it's hepatotoxicity being one that's common, and bone marrow toxicity. The issues related to genotoxicity have implications for both the causing of cancer, irreversible changes to the genetic code in any human. And we've been looking at that information both from people who have been previously treated for cancer with hazardous drugs, as well as in animal models. And I'll be referring to those when we talk about the fertility issues. And finally, there are drugs that are similar to a known hazardous drug. And I think probably the most recent examples of those are some of the biosimilars. And if it's a biosimilar to a drug that's known to be hazardous, we have to assume that there's that hazard potential as well in the biosimilar. So what about hazardous drugs and fertility? Certainly something I'm thought about. I'm a mother of 4. I think we all think about how to be our healthiest when trying to conceive, when going through a pregnancy, and certainly when breastfeeding and caring for a new baby. There are different aspects, as I mentioned, of reproductive toxicity. These can be effects to the fetal development, and these are referred to in the safety data labels, as you can see here, with an H and a number. So defects in fetal development are referred to as H10. Defects or damage to genetic changes, either directly or indirectly, are referred to as H6. And the actual induction of permanent changes in genetic material, mutagenicity, is referred to as H11. These are things you can see on the SDS labeling. So how do nurses get exposed to hazardous drugs? I mean, we think we're being careful. I think, at first we thought we were careful with gloves. Then we thought we were being careful with gowns and goggles, and then special gloves that would be chemoprotective, and gowns that were more, not cloth, but more protective. But we get exposed a lot, and it can be in the air, and it can be on our equipment. It can even be on our patients when we remove a line if there's still chemo in the drug. So pregnancy and fertility risks with chronic occupational exposure can be quite profound, actually, and the risks are often invisible. Nurses are handling, preparing, and administering anti-neoplastic drugs are at greater risk for health problems, including increased risk for infertility, fetal abnormalities, and miscarriage. This is very concerning. We noticed that in nurses, there was a 3-fold increase in menstrual cycle irregularities. That would point to the fact that there's an impact on the ovaries and oocyte production on a regular basis. So why is that happening? We're somehow getting exposed. In fact, if we look at the labeling from the Food and Drug Administration in the United States, of the 184 hazardous drugs on that original NIOSH list, 99 were considered a pregnancy category D. What does that mean? That there's risk to the fetus from evidence in human studies, but the benefits for a patient may warrant use, not for the nurse. And 43 additional drugs are in the most serious category for pregnancy worries, pregnancy category X. And this is fetal abnormalities in or risk to a human fetus, and the risks may outweigh the benefits, but that's for a patient with a disease, with a cancer that needs treatment, not for a nurse who's working every day. So why are so many cancer drugs hazardous? Well, because they work, right? They kill cancer cells. That's the whole idea. So those risks are to the cancer cells, but they're also to the normal cells. Many anti-neoplastic drugs have adverse effects, mostly on rapidly dividing cells, as we know, for all of us who deal with hair loss in our patients, or mucositis, or other parts of the GI tract that may be influenced by these drugs. But ova and sperm are also sensitive to cancer drugs. And after fertilization, those rapidly dividing cells could be a fetus. which may be damaged by hazardous drugs in the mother's bloodstream and may lead to genetic and growth abnormalities in the fetus. The high metabolic rate in the fetus leads to significant exposure to these drugs, especially if the mother is exposed through the skin, inhalation, or ingestion of hazardous drugs at work. Why do I say ingestion? Because sometimes we leave equipment on surfaces where other people may actually have food. And we've seen those issues where we should not be eating or having food or gifts from our patients on the same surfaces where we are working and handling hazardous drugs. So how are nurses getting exposed, right? We have PPE, we have gloves, gowns, we wear goggles. Well, typically it is through the dermal route. It's the skin, it's the eyes, it's the mucous membranes. And nurses have a great variety of ways they can get exposed in the preparation, the manipulation of oral agents, such as crushing pills like capecitabine at the bedside, so that a patient who may not be able to swallow a pill is able to take their agent. The administration, including the intravenous, subcutaneous, and procedural routes like intrathecal dosing. Intrathecal dosing often given in areas of the hospital that may not be familiar with how to handle hazardous drugs. Additionally, now we have subcutaneous agents such as rituximab, which is newly approved in the US, that can be administered in the home setting. So nurses maybe who don't have training in safe handling could be administering these drugs in a home setting. We can have another discussion about that. Drugs that are spilled, we never want that to happen, but it does happen sometimes. A failure of the equipment, in some places where there's still bottles, the breaking of a bottle if it falls off of the IV pole. So spill cleanups is another way that we can get exposed very, very dramatically. Excreta containing hazardous drugs, including urine, feces, and sweat. And inhalation from some drugs, and this one I find very concerning, which can vaporize at room temperature. That means they can aerosolize at room temperature. And this can happen during compounding, this can happen during spills, and these are commonly used drugs. And if you see at the bottom here, these are some of the drugs we use very commonly: cisplatin, cyclophosphamide, etoposide, 5-fluorouracil. So these are drugs that we're very frequently using that can aerosolize if there's a spill or a hazard during compounding. So now that I've scared everybody, what are we going to do? Because we still want to take care of our patients and we still want our jobs. How are we going to take care of ourselves and our colleagues? And how do we take care of our future children? So before pregnancy, I want to talk about what some of the impacts are on development of the oocyte, the ovum, the egg, and the sperm. And I'm going to go to some of the issues that we've seen before that I've talked about with this increase in menstrual cycle irregularities, and also what we've seen from treatment of cancer survivors and looked at their fertility going forward and where we've seen the changes. So ovaries, as we all know, usually have a monthly cycle of oocyte development, and the drugs can damage follicles, decreased ovarian volume, and actually lead to fibrosis. For sperm, it's actually a 2-month cycle. So for men, the drugs can be damaging sperm and decreasing sperm counts. So the recommendation I would make is that, first of all, we need to be discussing potential pregnancy with our partners, as well as with our bosses. Not always an easy conversation. But because of the issues of the effect of these hazardous drugs on ovaries and sperm, whether you're a male or female nurse, you're going to have a partner, you want to avoid exposure to these drugs for at least 2 months prior to trying to conceive. During pregnancy is probably one of the most dramatic and concerning parts of when we talk about hazardous drugs and nurse exposure, because the placenta is not an effective barrier to hazardous and anti-neoplastic drugs. And the fetus is not well developed enough to be able to metabolize these drugs. The amount of harm depends on the stage of development and the exposure and quantity of the drug. The first exposure in the first 2 to 12 weeks usually results in spontaneous miscarriage. Really, in a more general sense, the first trimester is when the most adverse effects can happen, the most critical damage to the fetus. Continued exposure throughout pregnancy has resulted in a 20% risk of congenital anomaly. And there's an increased rate in stillbirth from exposure in the second and third trimester. My recommendation is that for the first 84 days of pregnancy, roughly the first trimester, nursing staff should avoid working in high-risk areas. This is a conversation you're going to have with your boss to really understand how you can be involved in care, where you can be a nurse, but how do you have the best chances for your baby. After the first 84 days, nursing staff can work in these areas if they adhere to guidelines and use PPE. I'm going to say that again. If they adhere to guidelines for safe handling and use personal protective equipment. Let's move on to lactation and breastfeeding. There is an exposure to the infant during breastfeeding. Infants are very susceptible to these drugs via ingestion of breast milk after a mother's exposure through skin, through mucous membranes, through the eyes, during routine work. And the first 6 months are the most important as the infant develops organs and systems that can be involved in the biotransformation and elimination of drugs. Because their organs are immature, their systems may actually retain the drugs longer than when they get older. My recommendation is that lactating mothers should avoid working in high-risk chemotherapy areas. It's a big request, but I think it's worth it for our babies. Are there other ways that nurses can be contributing, such as patient education, support, telehealth strategies, where they can help their patients and not be working in high-risk chemotherapy areas to protect their babies while they're breastfeeding? If it's possible, think about alternative duties and work with your supervisor and your nurse manager and your sister to find out how you can find another way to contribute to cancer care during this very sensitive time in your baby's development. If you're working in these high-risk areas, because you have to, always follow the guidelines for safe handling of these hazardous drugs and use personal protective equipment. It's the best chance that you're giving your baby. So why do I keep bringing up personal protective equipment? Well, unfortunately, we're not as good at it as we'd like to be. We're not really following the PPE guidelines to protect ourselves and our babies, or even our families sometimes if we go home with our clothes with the hazardous drug on them. We found that in the United States and Canada, 38% of pregnant nurses reported never using a gown while administering chemotherapy. In fact, 9% of pregnant nurses indicated they never wore gloves when administering anti-neoplastic drugs, and 7% of pregnant nurses reported administering these drugs during the first 20 weeks of pregnancy, the most hazardous time. In Greece, there was a study that talked about the lack of adequate use of PPE during pregnancy. And in Turkey, another study, a lack of protection during pregnancy with widespread non-adherence to standards set by national and international labor organizations. We can do better with personal protective equipment. We all know about personal protective equipment because the whole world does now with COVID. But we need special personal protective equipment for the hazardous drugs that we handle in cancer care. Despite 4 decades of evidence to suggest adverse health effects for workers who handle hazardous drugs, nurses persistently do not wear PPE as recommended. We must be more careful. Our babies depend on it. A key guideline is that nurses should wear, at a minimum, chemotherapy gowns and double chemotherapy tested gloves when handling and administering anti-neoplastic drugs, whether via infusion or pills. When do we wear PPE? A lot. And I've seen lots of different ways that nurses do it. I still practice as a nurse practitioner in a cancer center. And I can't say that we always change gloves and gowns as we should. I mean, I'm just being realistic. We can be doing much better. And goodness knows the world knows about personal protective equipment now. We discontinue infusions, wear your PPE. When we're disposing of hazardous drugs, wear PPE. When receiving and unpacking hazardous drugs, wear PPE. I'm not going to go through all of these, but you can see that it is essential that we're wearing personal protective equipment to minimize our exposure to hazardous drugs. Currently, there's no reliable method for biologically monitoring for exposure for hazardous drugs. So we must create safe working environments. We can't measure for this. We have to follow PPE and use PPE and follow the guidelines. A safe level of exposure cannot be determined for cytotoxic drugs, so we must reduce our exposure as much as possible. Work with employers and follow the guidelines, especially for people who are actively trying to conceive, men and women, are pregnant and/or breastfeeding, to refrain from exposure to PPE. It is the employee's responsibility to notify their employer. Nurses are leaders when it comes to quality and safety in cancer care, and we need to be leaders in safety for ourselves as well. We need to establish policies and advocate for the safety of nurses, especially those who may be pregnant, becoming pregnant, or during lactation. We need to support alternative duty for nurses planning pregnancies, men and women, to avoid high-risk exposure to these drugs. It's the responsibility of nursing staff to inform their employer regarding their decision to conceive, when they become pregnant, or when they're breastfeeding. And finally, nurses need to follow the evidence-based PPE guidelines to protect ourselves, our coworkers, and our families when we return home from work. Thank you for your time today. I hope you all stay well and healthy.
Greetings from Tallinn. My name is Kristi Rannos and I work in one of two comprehensive cancer centers in Estonia with 132 inpatient beds plus 31 daycare beds and treatment chairs in my clinic. Although safety equipment and guidelines are getting better, these alone do not make our job safer. Therefore, I made a checklist with 10 interventions based on current guidelines and empirical evidence of their effectiveness in cancer nursing. I believe the greatest safety achievement in oncology is that also in our hospital, all cytotoxic preparations are supplied by the hospital pharmacy. All tubing already pre-primed with non-drug continuing fluid and closed systems. Drug devices are used always. However, these devices should be tested before buying because these may not function and protect workers as advertised. Also, device-specific training are important to receive maximal protection. In fact, the availability and use of engineering controls have been resulted with 0 spills and no hazardous drug-related adverse events among cancer nurses in the United States and have increased nurses' use of safe handling precautions in Turkey. Safety guidelines should be accessible with very clear instructions for all workers involved before, during, and after handling hazardous drugs, including specific guidelines of women during pregnancy and breastfeeding. But we do not have this in writing yet. But even more important than the guidelines is to allow employees to comply with them. Give them adequate time to learn and adequate time to adhere to guidelines during their everyday work. Also, put the contact information for questions and suggestions in the most visible place on nurse's table. And you can get in return from the employers more use of engineering controls and personal protective equipment, together with all kinds of safe handling precautions. Next, for both the staff member and the nursing manager, the main concern with personal protective equipment is whether there are enough available, located at the point of use, meet all safety requirements regarding to hazardous drugs, and function as advertised. However, the key for better equipment usage is employer familiarity with safe handling procedures, which can be achieved through regular training and monitoring the correct use of equipment. There is evidence to be convinced that nurse perceived availability of personal protective equipment and correct use of these can avoid hazardous drug-related adverse events and spills, and increase the usage of other handling precautions too. Now, make sure all workers have an access to Cytotoxic Spill Kit. This should be kept at reach in all areas where hazardous drugs is handled or where the patient decides to stay while receiving treatment. Also, spill kits may not include everything needed. For example, you may need a bathrobe for an employee who takes off all clothes in the contaminated area. Make sure all fits to the workers too. As spills occur 0 to 2 times per year in our units, usually due to the package defect or restless patient, and as most staff have luckily no real experience, the staff need regular trainings to be prepared for this. As expected, having more precautionary measures in place was a strong protective factor for cancer nurses in the United States and showed nurses that management takes the problem of hazardous drugs exposure seriously and values the health and safety of employees. As a leader and a teacher, I am constantly looking for effective educational interventions that have been successful for making nurses' behavior safer. Here is what I have learned. Firstly, make this education easily accessible. Use 30-minute online videos shared with all nurses in the unit. Let participants to choose whether they complete the education during or after work hours and compensate for their time. Secondly, target the education program to individual knowledge deficit, which should be identified through assessment and observation before the training. Third, do it on an evidence-based basis, because if participants do not find it useful, they will pay no attention to it and will not accept it. Fourth, always combine audiovisual learning material with monitoring and individual coaching, and give direct and frequent feedback to each participant. For example, nurses who will not choose the correct personal protective equipment will be corrected immediately before proceeding the drug handling. Fifth, provide written materials and videos and send reminders by email 6 months after training. And repeat training at least once a year for both beginners and experienced, because people forget and become careless. And if you've been a successful trainer, you'll finally see what you worked for. Nurses, improved knowledge of chemotherapy, more use of safe handling precautions and personal protective equipment, correct donning and doffing of the equipment. So if you haven't got those results, you probably have to change the educational intervention or find out the barriers for nurses to learn and act accordingly. Environmental surveillance involves mostly the use of wipe samplings at least semi-annually to measure hazardous drugs contamination on various surfaces. We do not use surface wipes in hospital, but these should be systematically implemented at all workplaces. Therefore, our pharmacies, together with cancer nurse managers, should start now to determine the frequency, location, and drugs for which wipe sampling is needed. Also, plans should be devised for making use of test results, with ongoing assessment and standardization of surface monitoring protocol. All this is worth the effort because with wipe tests, we promote a safe environment for all healthcare workers, patients, and families, and find out ineffective cleaning procedures in remaining contamination. With medical surveillance, I refer to a medical program to monitor workers' health as a result of potential exposure to hazardous drugs. Whereas the main causes of sick leave among nurses are due to biological, physiological, and psychological risk factors, the chemical and physical risks are generally not much reported or recognized at all. And injury data is not always documented. It is also difficult to assess how much drug is absorbed in the course of handling agents at the workplace. There is no standard protocol and lack of guidance on what to do with the results of medical surveillance either. Thus, as a nurse manager, you can develop the database by collecting data as a baseline of workers' health and provide means of early detection if a problem develops. Even normal absences should not be attributed to health problems when they are work or hazardous drug related. Also, long-term risks of handling newer drugs need to be discovered yet. All staff of reproductive capability must understand the risk of exposure to hazardous drugs and have to be extra careful or being offered non-hazardous drug-related work during pregnancy and breastfeeding. That means we can easily identify available options of alternative duty for those women and inform staff about these. While there are about 10% vacant nurse positions available in our hospital, these nurses are very expected in any other healthcare settings. Although this usually means that nurses have to leave the chemotherapy or radiotherapy units during their pregnancy. If they choose to stay, nurse manager recognizes the workflow, reorganizes the workflow so that this nurse does not have to perform drug-related tasks. For example, she can consult new patients or work as a nurse consultant who answers patients' call related with hazardous drug side effects, like this nurse in the picture. Or she can be a coordinator of some nursing processes and projects. However, in most cases, our cancer nurses choose to take sick leave throughout their pregnancy because they do not want to do other job and not to risk with being exposed to hazardous drugs either. Usually, nursing students take contemporarily their shifts, and other nurses work with a heavier load to take over her hazardous drug-related tasks. Next step in my to-do list is to develop working conditions that improve the patient safety culture and occupational health and well-being of workers. In order to reduce hazardous drug exposures, managers should monitor and correct heavy workload, optimize the number of patients per nurse and the number of hazardous administrations per nurse, and provide adequate time for using safety precautions. But the reality is that even that in every month nurses voluntarily work overtime to get a better salary. Although working with more than 1.0 workload in one workplace is not allowed, they take another job in another institution. And if there is a shortage of cancer nurses in the unit, nurses do extra shifts and work even more intensively. But this can be only temporary solution because as they get tired, we have to close the bed occasionally. The situation is aggravated by the fact that we have only 6.3 nurses per 1,000 inhabitants, and there are no official standards to optimizing the workload and for the nurse-patient ratio in oncology. Therefore, in addition to the constant recruiting and motivating the staff, nurse managers must also work to ensure that more nurses graduate basic education and receive better salary. Again, this is a challenge has been accepted to achieve less hazardous drug exposures, spills, and adverse events, more use of safe handling precautions, and reduced potential for cross-contamination. Based on the empirical results, many, if not most, occupational safety problems can be tracked back to organizations' safety culture as their basic or primary causes. While this will be the focus of the next webinar, I will only list here the questions I ask myself and others in my daily work related to safety culture. First, do you care enough in order to commit on safety and support other safety actions? This question is addressed to both managers and employers. Second, for things to really work, do you listen to the concerns and suggestions of employees and involve them in the multidisciplinary decision-making process? Third, do you understand and perceive the individual vulnerability and severity of side effects for your personal health? Without this, the safety and protection is only fictive. Fourth, can you speak up for safety? To achieve this, we have to reduce the historical hierarchical structure between positions and professions. We have to develop appreciative management and multidisciplinary teamwork and encourage openness in communication. And last but not least, are you ready when occupational exposure still happens? For this, develop and support and follow-up plans for workers. Minimizing potential damage to health and learning together from the case is an important part of further prevention. And if you do, you can be sure that you have increased occupational and patient safety in a most sustainable way. Thank you for your commitment and contribution. Be informed, be prepared, be safe.
Welcome everyone back to the break room. So right now, what we are going to listen to, it's three amazing colleagues who have shared their experience from their own countries with us. So we have Gabi from Germany, Annie from Georgia, and then Joanna from Greece.
Hello, cancer nurses in Germany don't handle cytotoxic drugs when they are pregnant or breastfeeding. This is regulated by various legislation and ordinances. The Working Condition Act and the Occupational Safety Act, which contains general and specific guidelines, for example, on the handling of cytotoxic drugs. We have a Hazardous Substances Ordinance by the Federal Institute for Occupational Safety and Health. Also, there are Maternity Protection Act. The purpose is to ensure that the pregnant or breastfeeding woman is not exposed to any hazards at her workplace. This is enforced by the current Maternity Protection Guideline. This guideline establishes uniform standards to protect the health and improve the safety of pregnant and breastfeeding workers, also protection against dismissal and ban on night shifts. The Professional Association for Health Service and Welfare regulates the risk assessment for work with hazardous substances. Depending on the risk assessment, follow work ban, change of department, or the assumption other task in your department. This sounds perfect. But if you are allowed to stay in the department after the risk assessment, there is a risk of contamination due to the non-performed environment monitoring, like wipe tests, especially in the outpatients area in Germany. Examples for improvement are monitoring studies on essential vibe tests and regular training for nurses, with the German Cancer Nursing Society recommendations for handling cytostatic drugs to improve the knowledge and awareness, especially on contamination risk and legal basics. So, thank you. Bye.
Cancer nurses in Georgia do handle cytotoxic drugs when they are pregnant or breastfeeding. Unfortunately, some of them have contact with cytotoxic drugs. This survey has shown that 10 out of 15 oncology nurses were pregnant during the working as an oncology nurse. 8 of them terminated their pregnancies. There was a case when 9-week pregnant was working without special equipment. The syringe burst was damaged while taking medicine, and the whole medication was poured over the pregnant woman. As a result, it caused the termination of pregnancy. There was another incident when a nurse switched medicines. It was leaking in the various drugs for several days. She was not well equipped, so her pregnancy also ended with a bad result. She was 8 weeks into her pregnancy. Until those incidents, their pregnancies were without any complications. Georgia has always posed certain problems because oncology nurses during pregnancy and lactation do not always have alternative activities to produce. Unfortunately, the legislation which should regulate the relevant actions is minimalist and vague. Therefore, to make a decision on safe work for pregnant and breastfeeding nurses depends on the goodwill of the employer. Despite some difficulties, some clinics in our country trying to give them safe work, oncology nurses during pregnancy maximize their safety with appropriate equipment, which includes individual means of protection, such as a disposable coat, a hat, a respirator, appropriate gloves and goggles. Therefore, it reduces the adverse effects of cytotoxic drugs on medical personnel during pregnancy and lactation.
Cancer nurses in Greece do not handle hazardous drugs in pregnancy and breastfeeding period. There are specific laws and regulations regarding this matter since 1997, specifying that pregnant women should be removed for their position with handling hazardous drugs to a safer workplace environment or take their legally predefined leave of absence. After giving birth, the time of work is approximately 1 year, so in this time they have the time to breastfeed their baby and then go back to work. There aren't any specific issues regarding this matter. There seems to be a major respect to pregnant and breastfeeding women, and this applies to public and private clinical settings. There aren't any initiatives, but the Hellenic Nurses Association, as well as the regulatory body of nurses, have highlighted this issue and its importance to the hospital's administrations and the Ministry of Health.
So, welcome back, everyone. We will wait a second for everybody to connect again, but thank you so much to the presenters. Thank you, Lisa, and thank you, Christy, and also great to hear from our colleagues from Germany, Georgia, and Greece. We can see that we don't handle hazardous cancer drugs in the same way across Europe. There's many differences between countries, as also Celia said in her introduction. So, and I'm sure that this session have raised a lot of questions from many of the nurses, probably slight worried about how do we really do it at our clinic. So we got some questions, and there's time for everyone to write up questions in the chat. But we have I have some questions, but there was also another question. I think we can start with asking Lisa, what is a high-risk chemotherapy ward? And also, can you work in these wards if you don't care for the chemotherapy patients?
Thank you, Lena. Those are excellent questions. And as you noticed from my presentation, I looked for the evidence to help us decide, what are the best ways to stay safe when trying to conceive or being pregnant or breastfeeding. So are there ways to have alternative jobs? And my first recommendation is, if you don't have to handle a hazardous drug, as in you can be on a ward but not handling the hazardous drug, you can do routine care, symptom management, blood transfusions, IVs, lots of other things that can be done on a ward that do not include handling a hazardous drug.
So thank you very much for that clarification, Lisa. I also will take a moment to congratulate you, because Lisa have just received a new title that I think is the coolest thing I ever heard. She's a global nurse consultant. Isn't that cool? So congratulations, Lisa. I know it was clear just last week. Fantastic. There's also another question, and it's related to gloves. There is Constantina asking if is it important to use chemotherapy gloves, double gloves? Should we use double gloves, or is it okay to use just single chemotherapy gloves? I don't know who of you wants to respond to that question. I'm not sure, but Constantina, right? I'm not sure, but I think it can increase the risk if you wear double gloves because it's air in between them. Is it any of you that want to respond to that? Christy or Lisa?
I guess the risk is still lower than not wearing gloves at all, of course. And the one thing is that there are different tests have been made with gloves. Some of them are usable for hazardous drugs, and the others are not so much. And if they are not so much, it is always better to use double gloves. So I understood that. I don't know if it answers the question.
Yeah. What do you say, Lisa? Do you agree, or what do you think?
So this is an interesting issue. And as you know, last year, when COVID unfurled, we had to modify our recommendations for PPE and think about, what did you have available? What did the rest of the staff have available for personal protective equipment? And think about, if you had the best of everything, what would you use? And if you didn't have it, what else could you use? So we literally stratified personal protective equipment, thinking about the entire healthcare system and what it meant for everybody to have what they needed to stay safe in healthcare. The top of the line are double gloves, nitrile chemo tested gloves. That's top of the line.
Yeah. And we are happy to say as well that the next webinar in the series will be covering PPE even more in detail. So we will come back to that. Another question is also about being exposed when you breastfeed. I mean, I think I missed the name, but there was a nurse saying that she have a little girl that's just a year old. Yeah.
Ines.
And what is the recommendation? I suppose you've said that, Lisa, already, but could you say something more about that? What do you do if you have a 1-year-old that still breastfeeds?
Right. I mean, so these are the difficult recommendations. I really look through the biological evidence from animal studies, from young adults who have received chemotherapy, and the impact that that's had on their fertility and on their children. In a dream world, we wouldn't be breastfeeding and handling hazardous drugs at the same time. It's not in the best interest of a child. Their organs are not well developed. Their biotransformation of drugs is not as good. I think that the longer you can go not being exposed to hazardous drugs, it's better for the babies.
Yeah, and I mean, what we say in EONS, because we're really trying to impact the legislations in the EU right now, and we say the precautionary principles of the rule. So if you can avoid exposure, you should really try, like you said also, Lisa, and also you, Christy, in this precious time, of your life, you should try to do everything you can to protect your baby. I think that's very important. There's loads of questions coming in here. One is also from me. You told us, Lisa, a little bit more. You told us about the risk for, you mentioned leukemia, for instance, as an occupational risk. Can you say something about the risk for breast cancer and other solid cancers with occupational exposure?
Yeah, that's a really good question. There's less information about that. And I have to say, in the United States, as much as we wanted to develop a registry to keep track of nurses and their exposure to particular drugs, as well as to chemotherapy, particularly cytotoxic chemotherapies, it doesn't exist. You've done a much better job in Sweden, frankly, tracking occupational exposure. So we don't know exactly what all these are, but we have found over time this increase in myelodysplastic syndrome, sometimes leading to chronic myelogenous leukemias. So that one seems to be a little bit more defined. The other types of cancers that we could be at risk for, we're not sure about yet. And if anybody else, I mean, Christy, you may have some more information as well. You know, until we track people over time, we're not going to understand the actual impact of routine occupational exposure.
Yeah, exactly. And I see a lot in this chat here. People are asking about when you try to conceive, and I think that's caused some concerns, and both for men and women, because I don't know if it's any country in Europe at least that really protects men and women. So it's really something we have to look into more. So very important topic. And also to you, Christy, you talked about in your session on leadership, which I think was very important, how important it is with the yearly training. And for instance, with spillage, and you're totally right, not everybody have experience because they've not been in a situation, but they still need to practice. How do you organize this? How do you make it happen every year?
Yes, thank you for the question. Actually, this is really planned from the pharmacy department already, twice a year, or how the schedule is made. So this is regular, really, that they come and give the lecture and presentation, and then nurses can practice with the spill kit. Actually, they can open it and make it all through, so that they will be prepared, because yes, this is really rare in our departments, and they have to be ready when it happens.
Yeah, and I suppose it's the rare situation where you need to practice, because the rest you get practice in your clinical work, so important. And you also gave us a few examples on how you said that you need to make it easier for nurses to improve their working condition. I think that was a very interesting way of putting it from a management perspective. So, and can you tell us a little bit more? I know your research field is safety culture, and I know you've done some really interesting work there. Can you tell us a little bit more on how you really make that happen among your staff?
Yes, I know the safety culture topic will be another webinar topic. So,
yes.
But the main question in our country actually is making nurses' safety voice more sound. So the main issue is that they will speak up when they see something wrong. And actually recent research in this field showed that nurses have often very ethical dilemmas in their workplace and ethical conflicts, and they are mostly related with the patient safety issues, actually, where they see something what is wrong, but they are not ready to speak up about it. I think it comes from the hierarchical structure in the hospitals, what we have still. remain. Yeah.
And we get that in EONS from nurses in all countries in Europe still, that you don't feel that you can speak up, or somebody having a bad experience that they tried and they were told off, or they should just obey or something like that. So I think we have more work to do here. I also have another question for Lisa, and that's about safe level of exposure, because you did mention it, but I wonder if you can say something more about that, because we often hear from commercial partners and others that, well, we have to treat our patients, obviously, and we do agree, our patients need their treatments, but as long as you keep within the safe level of exposure. Can you say something more about that?
Oh, goodness, Lena, that's such a great question. I think I used to work in radiation oncology, right? So you had a badge, right?
Yes.
And you can
exactly.
understand what your exposure is.
Yeah.
We don't know what that is
No.
for handling cytotoxic chemotherapies. For that matter, if we expand it into the newer agents, we don't know what the exposure to monoclonals or immunotherapies can do to our own immune systems, right?
No.
So, we don't have that. And I think there's a lot of work that needs to be done. And I think nurses are the best ones to advocate for that work, whether that's registries, following people over time to understand the risks. But until we have those numbers, our best safety is what Christy talks about, is using personal protective equipment appropriately all the time.
And we know now that it's coming on the market, commercial products that actually can do wipe tests. You get the response in 10 minutes. And we see that there might be a solution for when you spill, or if you're not sure about a situation. So I think we should demand better products here, because I agree with you, Lisa. I also worked over 20 years in radiotherapy. And you measure your exposure all the time. You never go into a radiotherapy unit without testing this. And it's the same patients. It's very often the same clinics. And this is we just need to improve the safety measurements also when handling these drugs. So I think it's a good comparison. And somebody writes here, after radiotherapy, there's no risk to have a blood test, but after chemo, yes, if there is, because the radiation is so low in their body. Yes, that's true. It's actually, I agree, there's probably less risks working in radiotherapy today, because the safety systems have developed so much than compared to handling the drugs. Okay, anyone that wants to raise a question? Now I've been reading up the question. Anyone that wants to raise the questions when you have both Christy and Lisa here? Anyone there too?
I had one more thing I wanted to share with all of you. I was thinking about these trends, especially that are growing during COVID, where people are trying to get cancer treatment in the home setting, or using more oral agents in the home setting. And often it's not oncology nurses doing some of these treatments. They haven't been trained in PPE, hazardous drug handling and disposal. And I think oncology nurses need to be advocating that patients who receive care in the home are getting the same specialized care that oncology nurses provide in an outpatient center or in an inpatient unit. And so I think we really have to be thinking about what the trends are right now, and what's going to emerge after this COVID era, on how we're going to be administering treatment, and what is the training of the people who are going to be administering these treatments.
Yes, and I totally agree. And that's why we EONS are working to try to get EU to decide on mandatory training before you handle these drugs. So you really can be aware, because if you don't have the training, you just learn from a colleague within a few shifts, you will not be able to be as careful as you need to be, I think. So that's very important. And I saw that Paz from Spain raised her hand and want to ask a question. You're welcome, Paz. Did we lose Paz? Paz Fernandez?
Now I can't.
Oh, here you are.
In the past, I do remember that there was the EONS test that was able to detect the metabolites in nurses when handle chemotherapy. But right now, I don't have any new information about. But in the past, they were, but it's not used by the institution or the cancer centers or the hospitals to test the nurses. So I do agree that right now radiotherapy is much controller than in chemotherapy units or in hospitals in general. But sometimes even nurses from urology or some other units also handle chemotherapy without any training or any procedures or protocols.
Oh, yeah, thank you for that, Paz. There is also somebody asking, would like Lisa to repeat how long before trying to conceive you should be extra careful with your exposure?
Yeah, thanks, Lena. So it's 1 month for women and 2 months for men. Obviously, it takes a partnership, so I would say 2 months.
Yes. And I can also say that there was a lot of information, and I think a lot of information that was very new to many of us as well. And I would like to remind you that you can view these sessions on YouTube afterwards, and we will send you some information and ask you to evaluate eventually. And also, if you take part in all 4 of the sessions, you can ask for you will get a certificate, and then you can take to your university and ask for credits for this, because we know that this type of education is not available in many of the countries across Europe. And we're also happy to see that there's people joining us here from all over the world, from all continents, which is fantastic. We should see if we have some final question before we finish at 8 o'clock. If patient before give treatment the high fever, what can I do? If patient, I'm not sure I understand. If patient before they give treatment the high fever, what can I do? I'm not sure that I understand that question.
I think he may be asking if a patient has high fever.
Yes.
If that is the question, I would say he needs to be reviewed before giving him treatment, especially a chemotherapy treatment.
Yes.
Because if he has an infection and you give him chemotherapy, what may cause him to his leukocytes, so white blood cell count, to drop, he may be in danger, real danger.
Yeah, I totally agree. And then we have a question about regulations, routines, about preparing and handling intravenous immunotherapies. You both, Lisa and Christy, mentioned that, and I think we need to be very careful here, because we don't know the long-term exposure effects, because these drugs are so new. So I don't know if any of you, Christy is putting thumbs up. I don't know if you want to add anything here, Lisa.
I agree with Christy. These drugs were not tested for the effects of occupational exposure on the nurse's immune system, or if nurses have pre-existing immune-related conditions, say rheumatoid arthritis or some sort of lupus-like condition where their immune systems are not working properly. We have no idea what long-term occupational exposure will mean for them. So that's to be determined. Until then, Christy, I would say use PPE. If you have it, use it.
Yeah, and be very extra careful if you are planning to be pregnant or breastfeeding. I think we all can agree about that. And I think the final question is about sweat. How should we think about that, Helena asks. I suppose it's to do with chemotherapy.
Christy, you want to handle that one?
Yes. Christy, do you want to say anything about sweat, how to handle that?
I think
only on the nursing webinar we can talk about these things.
yeah. I think that Dr. Lisa already covered that that this is the way we can be contaminated as well. So yeah.
So sweat is also body fluid, and we should be careful even there. So I think that's correct.
Yes, and this is also what we actually teach to the relatives of patients as well. Yes. Also about going to the toilet and flushing twice and such kind of things. Yes.
Thank you so much. And I think I want to conclude with thanking our speakers. This was absolutely fantastic. And we have just started this can of worms with new information and new knowledge, and we need to continue. And it's one of the main things for that EONS is doing this year, is trying to influence the legislations around handling these drugs. And that's a very important part of nurses' jobs. So thank you to the speakers, and also all the 326 nurses that registered for this webinar, which is absolutely fantastic. And before we stop, we will I will try to share the screen, because we want to highlight the next session, which will be, I should do it here. Yeah, the next, that was webinar 3. That was not my point. Oh, I'm so sorry. I messed up anyway, Celia. Helena, can you help me? It's what date is it in June? Well, it is
14th of June. Thank you, Eleonora. 14th of June.
14th of June, and it's about PPE. And this one is the third one about safety culture that also Christy mentioned. So sorry for messing this up. And remember, you can view this for 6 months, and we will ask you to evaluate. We know there was some trouble with some of the slides and some of the translations, but we will make it better next time, and hope to see you in June, all of you. Thank you so much.